Welcome to this explainer. Today, we're tackling a high-yield MSRA masterclass to lock down exactly how to manage respiratory emergencies. We're going to unpack the critical, life-saving differences between acute asthma and COPD exacerbations together. Here is our roadmap for today. We'll start with the core clinical divergence, walk through the acute severe asthma pathway, and then tackle the acute COPD exacerbation pathway. After that, we'll hit the summary and exam mnemonics, wrapping up with a rapid-fire MSRA 10-question quiz.
All right, Section 1, the core clinical divergence.
So picture this. You've got two patients rolling through the emergency doors. They both look completely identical, breathless, wheezing, totally distressed. But here's the catch. Treating one like the other, it's literally a fatal trap. In acute severe asthma, you are fighting severe hypoxemia caused by a VQ mismatch. That means high-flow oxygen is absolutely mandatory, and non-invasive ventilation, or NIV, is strictly contraindicated. On the flip side, you have your vulnerable COPD retainers. These patients face carbon dioxide narcosis if you pump them full of oxygen. For them, absolute oxygen control is paramount, and NIV is actually the go-to if they become acidotic. Moving right along, Section 2, the acute severe asthma pathway. This number right here, 94 to 98%, is your golden rule. For acute severe asthma, your target oxygen saturation must rapidly hit this range. Remember, asthma wants air. You absolutely cannot under-resuscitate these patients because hypoxia is the immediate overriding threat. So how does this play out on the ward? It escalates incredibly fast. Step 1, boom. Slap on a non-rebreather mask delivering high-flow oxygen and hit them with nebulized salbutamol, ipratropium bromide, and systemic steroids. Step 2, if they're just not responding to that initial therapy, you reach for IV magnesium sulfate as a smooth muscle relaxant. And step 3, this is absolutely crucial. Watch like a hawk for red flags. If you see them exhausting, if their chest goes silent, or, and this is a big one, if their PCO2 is normal or rising, forget about NIV completely. They are tiring out and need endotracheal intubation.
Okay, Section 3, the acute COPD exacerbation pathway.
Now, we're shifting gears entirely. Your new target? 88 to 92%. To prevent hypercapnic respiratory failure in a COPD patient, you've got to strictly anchor your target saturations to this much lower range. If you give them too much oxygen, you knock out their hypoxic drive, and that leads to deadly carbon dioxide retention. Notice the absolute precision required here compared to asthma. Step 1, initiate controlled oxygen via a 24 or 28% Venturi mask alongside your standard meds and antibiotics. Step 2, you must check an arterial blood gas, an ABG, at 30 to 60 minutes post-initiation. And step 3, if that ABG comes back showing a pH less than 7.35 and a PCO2 greater than 6 kilopascals, well, they've just crossed that acidotic threshold. That is your definitive trigger to start a trial of non-invasive ventilation, like BiPAP. Let's bring it all together. Section 4, Summary and Exam Mnemonics. This is your ultimate quick revision cheat sheet. Look at how the high-flow non-rebreather of asthma completely contrasts with the highly controlled Venturi mask of COPD. The danger in asthma? Hypoxia, so we push hard for 94 to 98%. But the danger in COPD is narcosis, so we deliberately hold back at 88 to 92%. If an asthma patient crashes, we intubate. If a COPD patient turns acidotic, we put them on NIV. Oh, and for second-line IV drugs, asthma gets the IV magnesium sulfate. You've got to cement these memory anchors in your mind for exam day. Asthma wants air, COPD keeps it cool. Seriously, say it with me. Asthma wants air, COPD keeps it cool. And never, ever forget the second rule. A normal or high PCO2 in an asthma patient isn't a sign they are stabilizing. Actually, scratch that. It's a silent, acidic, pre-arrest sign. If their chest is silent, they aren't getting better. They are tiring out and crashing.
All right, time to test yourself. Section 5, the MSRA 10-question quiz. Get ready to literally shout these answers out your screen before they appear. Let's see what you've actually retained. Question 1. What is the recommended target oxygen saturation range for an adult presenting with a severe asthma attack? Remember our mnemonic? Yep, it's 94 to 98%. Asthma wants air.
Question 2. What is your target saturation range for a stable patient with known COPD presenting with an acute exacerbation who is at risk of hypercapnic respiratory failure? Keep it cool. You guessed it. The answer is 88 to 92%. Moving right along. Question 3. Which specific oxygen delivery mask must you initiate in the emergency setting for an acute COPD exacerbation to precisely control those inspired oxygen fractions? Hint, you can't just use standard nasal cannula here, right? You need the Venturi mask, typically the 28 or 24% valve.
Okay, question 4. Imagine this scenario. A patient with acute severe asthma completely fails to respond to initial nebulized bronchodilators and systemic steroids. Which intravenous adjunct should be administered to induce bronchial smooth muscle relaxation? Think back to our escalation pathway. Bang, it's IV magnesium sulfate.
Halfway there, question 5. Why is non-invasive ventilation strictly forbidden as a primary ventilatory support method in an acute severe asthma attack? This is a massive safety point. It's because it delays life-saving endotracheal intubation in rapidly fatiguing patients. And honestly, it just doesn't effectively relieve that severe dynamic hyperinflation or bronchospasm. Let's check out question 6. Your COPD patient has a repeat ABG showing a pH of less than 7.35 and a PCO2 of greater than 6 kilopascals despite medical therapy and controlled oxygen. What is your immediate next step in ventilatory management? Well, they've crossed the acidotic threshold, so you immediately initiate non-invasive ventilation, typically BiPAP.
Question 7 tackles those red flags. If that PCO2 normalizes or rises above normal during an acute asthma attack, what terrifying clinical trajectory are we actually looking at? It indicates impending respiratory arrest and severe fatigue. They need immediate intubation. For question 8, let's look at the underlying physiology. What is the actual primary mechanism behind high-flow oxygen causing narcosis in susceptible COPD patients? It's a dual threat. You get a loss of hypoxic pulmonary vasoconstriction, which leads to increased dead space, combined with the Haldane effect, which displaces CO2 from hemoglobin.
Almost done. Question 9. Before you even get an ABG, what specific initial high-flow oxygen mask must be slapped onto that severe asthma patient? Don't wait around, you go straight to the non-rebreather mask with the reservoir bag. And finally, question 10. After initiating controlled oxygen therapy and medical management for an acute COPD exacerbation, exactly when must you check that arterial blood gas? The clock is absolutely ticking here. You need to check it within 30 to 60 minutes. As we wrap up this explainer, I want to leave you with a final thought to really test yourself. If you encountered a breathless, wheezing patient right this very second, are you truly ready to recognize that split-second fork in the road? Knowing the difference isn't just about passing the MSRA. It is about making the exact right call when a life is literally on the line. Thanks for exploring these pathways with me today, and always keep questioning what you see on the wards.